Hi everyone. I think we're about ready to start. Okay, great. So welcome everyone to our session on the diagnostic and screening algorithms for FGS in relation to purpose, context, and setting. I'm Ashley Preston from Unlimit Health, which was formerly the Schistosomiasis Control Initiative, and I've organized this session, and we've got a lot of interesting speakers as well. So the focus of our session is really because we have a lot of questions remaining around what's the best way, what's the most effective way to diagnose and screen for FGS. And we want to understand the important aspects of the approaches that are going to facilitate integration and also scale up of these approaches and provide a holistic service for women, not just focusing on one disease at a time, but thinking really treating women in that holistic approach. They're not just one disease, but they want to understand how they can receive treatment in the best way. The other aspects that we want to touch on in the session are thinking around what are the important components of diagnostics or screening. For example, there's been interesting research already combining different elements, for example, urine filtration or colposcopy or combinations of different risk assessment questionnaires. So really considering what's already taken place, what research and evidence do we already have, and where are the gaps. And of course, that's going to also depend on the context of the implementation. So thinking around if that is actually being implemented in a routine setting, or in, for example, screening and prevention, or thinking about it in a surveillance and public health context. And the other challenge that we're hoping to touch on and discuss today is around how can we actually diagnose across the spectrum of disease progression? How can we catch women at those early stages, and what does diagnosis or screening look like for those women? And then how can we also consider women who have already progressed to the later stages of the disease? So luckily we have some amazing speakers today, and we have interesting research from Tanzania, Ghana, Nigeria, Zambia, and also experience from Kenya. So we're going to start with 4 presentations today, and then have an opportunity for Q&A. So if you can please make notes of your questions as we go through, and then we'll have an opportunity to ask questions for all the presenters at the end. After the Q&A, there'll be a break for coffee, and then we'll come back and we'll have an account from a gynecologist explaining the context in Kenya. And then after that, we'll have a group discussion, and I'll explain more about that when we get to it. Some other important notes, and sorry, I should have said welcome to everyone online as well. So some other important notes, which I'm sure you've already experts on, but all the meetings are being live streamed to our virtual platforms and will be recorded for later viewing, so you'll have that accessible a week after these meetings. Also, live stream will pause when a session breaks into a smaller group for discussion, but then the video will come back when we come back after the small groups to report back. The breakout sessions do not have interpretation, unfortunately, so it'll all be in English. And also, please take a moment to note your nearest exits, whether that's behind or in front of you, and remain calm in case of any evacuations. So without further ado, I'd like to present our first speaker, Dr. Gladys Mubwanji. She's a medical doctor and epidemiologist, and also a research fellow from the Catholic University of Health and Allied Sciences. And she's going to present today on her research in Tanzania. So welcome.
Thank you. Sorry. Thank you so much, Ashley, for this introduction. And I'm really glad to be here to present study findings that I did with Prof. Mazigo. As the title of our study says, high sensitivity but low specificity of female genital schistosomiasis, risk factor, and symptoms, the checklist among women in Maswa district. So what is female genital schistosomiasis? So this is a diagram that illustrates in brief about female genital schistosomiasis. On this slide is the female reproductive tract, showing that the eggs are deposited in the tissue, which later cause inflammation and would lead to genital lesions that mimic features of female genital schistosomiasis. And on this slide, it also includes the urinary bladder, urethra, that is the urinary system affected by schistosomiasis. So female genital schistosomiasis is transmitted through schistosomiasis through the skin. The secondary goes to the body, and the adult worms mature, producing eggs, which are trapped in the female genital schistosomiasis, in the female genital tract. And so the female genital schistosomiasis is the clinical feature of urogenital schistosomiasis caused by the schistosoma hematobium. And from what is estimated on female genital schistosomiasis is that 56 million women and girls are affected by it, and most of them are in sub-Saharan Africa. And little is known on female genital schistosomiasis, especially in Tanzania, and most likely in Maswa district that we wanted to investigate. So this is the map of Maswa district. As you can see, this is Lake Victoria. It's one of the highly endemic regions for schistosomiasis in Tanzania. And 30 to 50% is estimated to be the prevalence for female genital schistosomiasis. So what are the symptoms of female genital schistosomiasis? Once the eggs are trapped in the female genital tract, they cause inflammation, which leads to immune response, which cause some of the signs and symptoms as highlighted on these slides. Some of them are vaginal discharge, bloody discharge, and bleeding after intercourse or spotting, genital itching, pelvic pain, pain during or after intercourse, and vaginal ulcers. So if the symptoms are not treated, what happens, it leads to complication. Some of the complications we have seen in most of the women in our settings is infertility, miscarriage, menstrual disorders, the premature birth, persistent abdominal cramps, and the increased risk of STIs and HIV. And it has some evidence has been shown on FGS is more likely 3 times, it 3 times increases the risk of HIV and STIs. So what does female genital schistosomiasis look like? The reference standard of diagnosing female genital schistosomiasis is the colposcopy. And through colposcopy examination, some of the features, characteristic lesions you might find are the granny sandy patches, homogeneous yellow sandy patches, rubbery papules, or abnormal blood vessels. So these ones can happen as one, or all of them, or a feature of 1 or 2 or 3 of them. So what is the treatment for female genital schistosomiasis? So from this study, we identified some of the criteria. We were using a checklist to identify the sensitivity and specificity, but also using the speculum examination or colposcope examination, and for women who had missed mass drug administration. But what does WHO recommend? It recommends praziquantel 40 milligram per kg as a single dose. Okay, so the aims of this study, the general aim was to to measure the sensitivity and specificity, but also some of the other objectives were to look at the performance of this checklist in comparison to colposcopy as a standard of treatment, and determine the prevalence and risk factors of urinary schistosomiasis. In a nutshell, the method, this is a cross-sectional study looking at the sensitivity of this checklist. And 347 women underwent the questionnaire underwent the thorough questionnaire. Were asked through they were administered the questionnaire, which consisted of the checklist. And out of the 347 women, it's only the 177 women who consented for colposcopy examination, and it was due to cultural beliefs and the discomfortability of the test for these women. These are some of the pictures that we took during the study. In this context also, we included the urine sample, urine filtration method to diagnose urinary schistosomiasis. And in this study, all women were treated for praziquantel. So the checklist that we used was adapted from the Countdown project in Liberia, and it included the symptoms and risk factors. So 3 of the risk factors that we looked at were exposure activities to water bodies, descent from natural water sources and other sources, if women use other sources. So exposure activities, like swimming, women would score 5 if they said yes. And adding the risk factors in schistosomiasis, if women had more than 7 points, they're more likely to have FGS. And for the symptoms, these are the symptoms that were also in the checklist that was adapted from the Countdown. The genital bleeding, coital bleeding, and if they had any of these symptoms and said yes, they would be given 2 points for each symptom that they had. So in a nutshell, the results for this study were that most of the women were in this age group of 25 to 30. And from this summary, we can see that more than 50% of women in this rural population contact freshwater bodies. And more than 90% of these women, they reported no use of praziquantel. These slides highlight what I just said. And looking at the sensitivity and specificity of this tool in reference to colposcopy as a reference, it had shown 85% sensitivity, which is high, and very low specificity. And yeah, so for the urogenital schistosomiasis, we can see that it's only 3.5%, which is different from what we saw from the school-aged children in 2021. And the colposcopy findings, we say in the previous slide and the method, I said 177 women underwent colposcopy examination, and out of this, we could see that 28 of them, which is 16%, had genital schistosomiasis by colposcopy, which was something different we saw from the questionnaire, which was 87%. Looking at for women who scored more than 7 were positive, and those below, so we got 87% that were FGS by checklist. And most of the common features we found in our study that mimic FGS were the homogeneous sandy patches and abnormal blood vessels. These pictures are from WHO, and these ones are from the study we did. And if we're looking at the checklist and using the score point of 7 as a cutoff point for positive and negative as FGS, it showed that women who were fetching water for both unadjusted and adjusted had more risk of having FGS, likewise, which was also seen for women who had pelvic pain and urinary symptoms. And so in conclusion, from this study, we saw that women, this tool has shown high sensitivity but low specificity compared to colposcopy as a reference standard of treatment, of diagnostics. And it's still a tool that we'll need to evaluate more in other different population and age structures. Thank you.
Thank you very much, Dr. Gladys. It was really interesting to see the different components you'd used in the diagnostic algorithm. So if I can now just introduce our next speaker, Dr. Joseph Opare. He's the Senior Public Health Specialist and a physician, epidemiologist, and Fellow of Ghana College of Physicians. And also in his role as the NTD Program Manager, he was involved in the FAST package in Ghana, and he's going to speak about his work in Ghana today.
All right. Thank you so very much, Ashley. Ladies and gentlemen, I'm going to talk on the perspectives from Ghana and FAST work done on FGS diagnostic algorithm and challenges we faced. All right, so this will be the outline of the presentation. A lot has been said already on female genital schistosomiasis, so I'll skip this slide if you permit me. Okay, and continue by saying that we found a prevalence of 10.6 in somewhere in the Volta region of Ghana. That is one of the current statistics that we have. Then the high prevalence of schistosomiasis suggests a high likelihood of FGS being a major problem. So that is the other point that we noted. And FGS is often misunderstood because most of the signs and symptoms mimic the normal sexually transmitted infections. So most of the time it's being misdiagnosed by healthcare practitioners. Then the social problem of stigma, social isolation, and broken relationships, and often psychological distress for affected person. You know, from this condition, it could result into ectopic pregnancies, infertility, and all that. And also, the male component could lead to infertility as well, sterility as well. So, with the highlights from the FAST package, that is female genital schistosomiasis accelerated scale together package, we have a component of diagnosis and treatment, training of medical personnel on FGS, awareness creation and prevention of new cases. And we have the FGS National Committee pushing the agenda of the FAST package. So this kind of gave us some highlights into FGS at the initial stages. So typically at the health facility, when a client in an endemic area, or if a lady comes to the health facility, the health worker, of course, will listen to the patient's complaints, take detailed history of the client, place of residence, duration of stay, and current residence, presence of water bodies at the place of residence, occupation, and many more questions. Definitely we do that routinely. Especially we did this in the trained districts on female genital schistosomiasis. And with a clinical diagnosis, speculum and colposcopy when applicable using case definitions. You know, the very young ones, we don't do colposcopy, but for the reproductive age group, we do that. And if it's found positive, then we treat with praziquantel, and also we do a follow-up and advise on prevention of STH. Right, so these symptoms, I think we heard all of that from the previous presentation when it comes to FGS, right? But we are using the case definition, right? And the first one is when to suspect. And we are saying that a woman or girl coming from a schistosomiasis endemic area with a complaint of pelvic pain, itching, unexpected bleeding, spotting discharge, subfertility, infertility, or ectopic pregnancy, we do suspect. Then a presumed case above with resolution of symptoms with treatment with praziquantel and history of blood in the urine. Okay, so what do we say here as a confirmed case? We need blood or egg in urine or any genital sample, histopathologic fluid, pap smear, swab, vaginal lavage, and all that. Then for the sexually active females, FGS lesion seen by pelvic speculum examination in the vagina and cervix. And FGS is diagnosed by usual visual inspection of characteristic lesions on the cervix and vagina wall by speculum or colposcopy. And I think we saw on and also watched the details from the previous presentation. I don't know whether I can show this, but okay. I wanted to show you the format through which we capture data on FGS in our District Health Information Management System. Over there, we capture the age, the number of cases, the age, and so forth. But for now, we don't have whether it was a suspected case, presumed case, or confirmed case, right? We don't capture that. It's either positive or negative. Yeah, so that's what we have. And moving forward, we plan to work on that as well. All right, so in our case, when should one suspect FGS? All women or girls who present with urogenital symptoms and history of recent contact with fresh water in an endemic area. And with Ghana, in almost every district, we have this condition, in every region as well. So it's like all over in Ghana, right? And most of the time, when you treat for STI and you are not getting better results, you do more history, and you find out this person is coming from an endemic area, which is almost everywhere in Ghana, then you have to continue with the praziquantel. And in most cases, you get some better results. And it's like seeing a case of FGS means that there are so many elsewhere, provided they use the same source of water, right? So this is the normal service as we saw. This is what we are using, the homogeneous yellow sandy patches. And we found out that it's very common in Tanzania. It's also common in Ghana, right? These ones and so forth. But we have some challenges if we want to move this agenda forward. So we have poor knowledge of FGS. You know, FGS wasn't taught in the medical schools. At least when we were there, we were not taught about FGS, right? But it's a new concept now that many people are trying to get more knowledge on. Good. So in Ghana, we have started in 25 districts out of 261. We have some training done. So the question is, what happens to the rest of the districts? We need to train them so that they can also use the colposcope, the speculum, and diagnose these cases. And funding gap has been an issue. And even in the trained facilities, access to a colposcope sometimes is a challenge. You may get it only at the hospitals. Right. Then, even if it's there, training on how to use the colposcope is also another issue. And sometimes attrition of nurses is an issue, especially in the northern part of Ghana. Yeah, then also a few times, even when we've done the diagnosis, treatment with praziquantel can also be an issue, right? So this is where we've got into, and we are grateful to all the support from these partners, including WHO. Thank you very much.
Thank you, Dr. Joseph. It was really interesting to hear about the case definition and the importance of that. So our next presenter is Dr. Akinola Oluwole. He's a research advisor at Sightsavers and also the program lead for 2 co-production research projects within Countdown, one of which was to develop a care package for FGS, and his focus area was in Nigeria. Unfortunately, he wasn't able to be here in person today due to visa challenges, so he's provided a recording, and also he's avidly following online, so please do still note any questions you have for him, and we can take a note and send them to him and hopefully get feedback by the end of the session.
Good morning, good afternoon, good evening, wherever you're watching from. I'm Akinola Oluwole, and I will be presenting on the perspective of the Nigerian work done on FGS diagnostic algorithm and challenges faced. Female genital schistosomiasis is one of the most neglected gynecological conditions with severe psychosocial and physical consequences, with 56 million women and girls in sub-Saharan Africa being at risk, and due to limited awareness among medical practitioners and overlapping symptoms with sexually transmitted infections, FGS remains largely misdiagnosed and unappreciated. Just to give a background, this study is an health system strengthening research conducted under the Countdown DFID-funded project, which was led by Liverpool School of Tropical Medicine and co-implemented by LSTM Sightsavers, the Federal Ministry of Health, Nigeria, and the State Ministry of Health in Ogun State, where the study was done. and due to COVID-19 and funding cuts, we could only do this study for 6 months. We made use of a participatory design, which is a quality improvement implementation framework, what we called PDSC, that is Plan, Do, Study, Act. This approach is participatory, which ensures the engagement of the different cadre of healthcare, both frontline health facility, primary health care, and the health professionals, leading to a development of a context-specific care and treatment for persons affected with FGS. During this study, we had a 3-day workshop to develop the diagnosis and treatment care, which led to the development of a training guide and the trainer manual. The health worker training guide had 5 sessions, but for the purpose of this presentation, I'll be focusing mainly on the diagnosis using symptom checklist and environmental risk assessment. Our FGS diagnostic algorithm made use of 3 basic tools: the initial symptom questionnaire, the vaginal color discharge chart, and the risk assessment tool. I'll be speaking more on each of these tools in the next slide. For the initial symptom questionnaire, when a woman of reproductive age presents at the health facility with gynecological or reproductive complaint or issues, it is expected that the health worker will administer this questionnaire, and we have each of these questions is expected to be asked if the patient had genital itching or burning, and the health worker is to ask the degree of the symptoms experienced, whether it's mild, moderate, or severe. Also, there's a question there which has to do with vaginal. Do you have a vaginal discharge? If the individual says yes, the health worker is to make use of the vaginal color discharge, which will be shown in the next slide. Then the level of discharge, is it mild, moderate, or severe? The pain during sex, the spotting or bleeding during sex, is it occasional, is it rarely? The level of severity experienced by the patient will determine if such patient needs further investigation. Hence, the health worker will need to refer such individual to the secondary or tertiary institution, as the case may be. This is the vaginal color discharge chart. When the frontline health worker asks the question about if the patient is experiencing any discharge from their vagina, if the patient responded yes, the health worker will present this vaginal color discharge to the patient to identify the color coming out from their vagina, the color of the discharge that is coming out from their vagina. If the patient points to any other color aside 1 and 2 above, which is whitish, which is either whitish or creamy in nature, then it's an indication that there is an issue within the vagina and within the genital, which the health worker will document and forming part of the diagnostics process. The next thing on our FGS algorithm diagnosis is the need to conduct a risk assessment, environmental risk assessment. If the patient has responded yes to any of the symptomatic questions that we have presented above, the next thing is for the health facility worker to conduct a risk assessment. This environmental risk assessment is one of the most important tools in our diagnosis, because since at that level there's limited access to the colposcopy, the frontline health worker will use this risk assessment to identify if the individual is actually at risk of having FGS or not. Otherwise, the symptoms experienced may be more of that from other sexual or reproductive issues. So to conduct a risk assessment, the health worker will ask the following questions. Basically, as you will see from this chart, there are 4, but the most important one is the first question. which has to do with if the patient has had any form of contact, whether active or indirect, or that means passive contact with water, whether current or previous, maybe in the past or in the history. So that question is very critical. If the individual says yes, it means it gives a score of 4, as you can see. But if the individual says not sure, we'll give that score of 2. And if you say no, it's 0. The other questions is if the individual have had any painful urination or bloody urine, which gives a score of 2. If there's anybody in the family or anyone who have lived with the history of blood in urine in your family, or if there's anybody in the community who have suffered from these symptoms. So each of these has a score. Now, from answering these questions, the health worker is to calculate the score. If the score is above 4, then it means that this individual is at risk of FGS, and then goes to check the treatment if the individual is eligible for paracetamol treatment. So the next thing is for the health worker to check if the patient is experiencing any other complications, so that such patient can be referred appropriately to the secondary or tertiary health care for further investigation. The health worker is to ask questions such as if the individual is experiencing involuntary passage of urine, if she has been having difficulty in getting pregnant, if there's any history of pregnancy loss, if is experiencing any ulcer or sore in the genital, ulcer bleeding or genital swelling. All these complications is just to check if the individual may need further investigation. On this slide, I just want to show you the overall flow diagram of the care pathway of the process that the patient will pass through to get catered for or treated for FGS. I have actually made mention of some of these stages, but particularly I want to show you, looking at where we have this circled red ring. After the health worker has performed the environmental risk assessment, if the individual score below 4, though experiencing all these symptoms, it is expected that the health worker will refer that individual for further investigation within the routine practice of other sexual or reproductive health care, so that such individual can get the treatment which is outside of FGS treatment. But if the individual score above 4, then it will go through these other processes. But for the sake of time, I may not want to go through that now. This is the treatment pathway for patients at risk of FGS. The whole idea of this is to check if it is safe to administer paracetamol to the woman who has been identified as at risk of FGS. The health worker is to conduct a pregnancy test to ensure that the woman is not pregnant, then to ensure that the individual has eaten before administering paracetamol, then also to ensure the patient is counseled to prevent reinfection and to reduce stigma. So this is a follow-up process. It is expected that after the patient has been treated, the health worker is to ask the patient to come back in like 3-5 days, or to call to confirm if the patient is still experiencing any of these symptoms. So when the patient comes, the health worker asks these questions again and also check the level of severity, and the response of the patient will determine if the patient would need to be referred for further investigation. This slide is just to show the eligibility criteria for those that will be treated with paracetamol. So this is to highlight the major key achievements. The key one is that about 79 women with gynecological issues were screened, and 66 of them had cases of FGS which were reported to have been resolved after being treated. Then there was increased health-seeking behavior of girls and women with gynecological issues without fear of being stigmatized. You can read all others because of our time. I will need to continue. So to talk about the lesson learned while developing the algorithm, first, there is need to understand the system structure and how it works. Another key thing we need to check, point 4 here, you need to understand the cadre of health workers are available at the primary health care facilities so that you know what capacity building is needed. And also, there is also very important thing is to understand the resources available at the health facilities so that you understand what kind of care package that need to be developed and the training needed. Talking about the limitations and challenges, the major one I want to point out here is about the recall bias of patients, whether they've had contact with water or not, especially if the water contact has been long. Then the issue of non-availability of Pasquatel at the health facility. We consider the sustainability of the FGS intervention, and we were able to build this around the WHO health system building blocks, and this is presented here for your read. This is to acknowledge the various partners that participated in the development of this diagnostic algorithm under the Countdown project. Thank you for listening.
Thanks very much, Dr. Akinola. And now, last but not least, we'll have our final presentation from Professor Kristen Wall. She's an Associate Professor of Epidemiology at Emory University with experience in biomedical engineering, epidemiology, and biostatistics. And she's leading research on FGS screening, diagnosis, and treatment in Zambia, which she'll speak about today.
All right, hello everyone. Thank you so much for joining us today. Again, my name is Kristen Wall. I'm an associate professor of epidemiology at Emory University, and I will be presenting some of our FGS-related work on development and validation of an FGS screening algorithm. I'll also very briefly mention some study results related to lesion resolution after treatment. So neither I nor my collaborators have any conflicts of interest. So as we've already kind of talked about, there are few routine FGS screening or diagnostic programs taking place in most sub-Saharan African countries. Zambia is included in that list. And the identification of FGS is quite difficult, due in part to some factors we've already discussed, including confusion of the signs and symptoms of FGS with STIs, or other genital abnormalities, dysbioses, including, BV, Candida, things like that. And additionally, there are feasibility and cost issues related to the gold standard way that we diagnose FGS, which is typically during colposcopy with expert review. So our study objective was to build a screening algorithm for FGS that could feasibly be implemented in a Zambian government clinic setting. So before I kind of talk about the data that we collected to develop this algorithm, I want to note some differences with our approach relative to some of the other speakers, which I think is kind of important when we're interpreting all of these data. So our study took place in two urban areas, in Lusaka, which is the capital of Zambia, and in Ndola, which is the either second or third largest city in Zambia, depending on numbers. So these are urban areas with very little known local transmission of schistosomiasis. So I think that's quite different from some of the other work that's being done. Additionally, we enrolled women into this study from what we call our high-risk women's cohort. It's a standing cohort of women that have been established by our research group for many years. And we call them high-risk women because they're predominantly HIV-negative female sex workers. And the incidence of HIV in this group is quite high, about 4% per year. And the prevalence of STIs in this group, as you might imagine, is also quite high. And I think that's important when we are trying to develop a screening tool that can differentiate STIs from FGS. You've got to have a certain, proportion of people with STIs. So we, again, we took a slightly different approach where we weren't using already developed screening algorithms. We were developing our own for this urban setting. And I also just want to note that, if you think about the other algorithms that we've discussed today, a main component of those is, as you would expect, repeat contact with fresh water, right? I'm swimming in fresh water, I'm washing my clothes in fresh water, et cetera. These urban women did not report those behaviors. So we felt like it was important to kind of do this proof of concept study to say, can we derive our own algorithm that would be relevant to a kind of different population of women? So in order to do that, we administered surveys that collected various demographic, reproductive history, gynecological history, and environmental exposures. So a laundry list of potential exposures that might end up in this algorithm. Our gold standard for FGS diagnosis, so this was our ground truth. We diagnosed FGS using expert review of images taken during colposcopy. We also looked for eggs, and we did hematuria testing for blood. We additionally conducted VIA tests, looking for cervical precancers, and gene expert testing for high-risk HPV types. We diagnosed various STIs and vaginal dysbioses, including HIV. We did RPRs for syphilis, and we looked for Candida, BV, trichomoniasis, gonorrhea, and chlamydia. We also conducted genital exams, looking for genital inflammation, vaginal discharge, endocervical discharge, ulceration, and adenopathy. So, and these results may surprise you, considering, again, this is women from urban, 2 large urban centers in Zambia, but the prevalence of FGS, again, diagnosed by expert review of images taken during colposcopy, was almost 24%. I'm just showing you here the kind of distribution of these FGS indicators that we've already seen. These images you've seen previously from Gladys's presentation. These come from the WHO Pocket Atlas. So you can see that the majority of the FGS indicators fell in the abnormal blood vessel group or the homogeneous yellow sandy patches. And this is the kind of risk algorithm that we've developed. It had good discrimination and calibration, and you can essentially, think about this as a checklist, similar to the checklist we've already kind of been discussing. So if a woman said, yes, I've had travel exposure to river or streams, she would get a point on your checklist, right? Or childhood exposure to lakes or ponds. We also had some demographic exposures, being born outside of Lusaka or Copperbelt, these urban areas. Not having heard of schistosomiasis, so a knowledge factor that is interesting, to think about in terms of it being potentially modifiable. And then some gynecological signs, symptoms, inflammation of the cervix, self-reported incontinence, blood in the urine on hematuria testing, and then self-reported history of genital ulcers or growths. So I don't have time to get into the methods of the algorithm development, and then we did some internal cross-validation and some external validation, but I'm happy to talk about those methods later if people are interested. But cutting kind of straight to the upshot, the evaluation of this, we, in a sense, found some results similar to Gladys's, where we see, a decent sensitivity. If we're just taking the example of a cutoff of 2, for example, a decent sensitivity, lower specificity. So, it's important to kind of think about, if we were to choose this cutoff, what does this mean? So we've got 30% false negatives and 44% false positives. It's kind of the penalty we're paying for maybe kind of casting a wider net, right? And, when we think about when sensitivity or specificity are prioritized, it's, very context specific. It's dependent on, the disease that you're considering. And I think that this is this bit about sensitivity is prioritized over specificity for screening when these criteria are generally true. I think this is very useful to think through when we're interpreting Gladys's data as well. So the disease is serious and treatable, which I would argue that it is, and I'll talk a little bit about treatability, as I said. False positive psychological risks are low. I think you could argue that, you know, relative to some other diseases, cervical cancer, for example, this could also be true. And the costs and risks of further testing and treatment are reasonable. So things to kind of, you know, think through. In terms of our predictive values, this is actually, again, sort of similar to some of your findings. So a lower positive predictive value, and I think that this sort of underscores that, you know, we're talking about here, at least, a screening algorithm. And, you know, predictive values are related to the prevalence of the disease in the group that you're studying. And, a real benefit of screening tools is to send a group of people who should have a higher prevalence of true disease onward. It increases what we call the pre-test probability of disease for those that move further down the cascade. So as I said, and I just have one quick slide on this I wanted to mention, we did do a small follow-up study in this work where we evaluated changes in lesion severity or potentially lesion resolution in a small group of women. So we followed up 43 women who were FGS positive, who were treated, and we followed them up about 6 to 12 months later and repeated our procedures, and we found that most experienced a decrease in lesion severity. We define severity as the number of those, a reduction in the number of those 4 FGS indicators that we've already looked at, or a reduction in the number of cervical quadrants involved. And then 23% experienced complete lesion resolution. And I think that this last point is important for our discussion of screening algorithms and potentially our discussion later this afternoon. Less severe lesions, and this is probably not terribly surprising, were associated with an increased likelihood of lesion resolution. And I think that really speaks to, something we've been discussing about, trying to catch disease earlier, right? And maybe that could lead to better treatment outcomes. So I'll just wrap up with some kind of thoughts about next steps. So we developed and validated this, hopefully quite simple screening algorithm. Again, targeted towards women living in urban areas. I think it's really important to note that we saw this very high prevalence of FGS in a population of women who are at very high risk of HIV. We would like to, kind of expand this proof of concept study, adapt and validate our algorithm in other settings. And then we also have schistosome-specific antibody data that we could incorporate into this algorithm for, potentially improved performance. So I would like to thank all of my colleagues at the Rwanda-Zambia HIV Research Group who conducted this study. Our study launched in March of 2020, which, as you can imagine, was a very difficult time to be launching a brand new study. But they did an absolutely brilliant job, and I am so fortunate to be working with this really amazing team of people. Of course, I would be remiss if I didn't thank our study participants and staff and our funders. Thank you.
Thanks very much, and particularly for walking us through some really key points that I think everyone will take note of for the discussions later as well. So now I'd like to pass over to Anouk Guvras from the Global Schistosomiasis Alliance, who's going to moderate our Q&A.
Thanks very much, Ashley, and thank you so much to our speakers. That was fantastic. I've made notes of questions, but I'm sure all of you have as well. So shall we, I don't know if we want to get speakers to come and sit at the front, or is that a bit too formal? Does it mean to make them do that? I'll pass them the microphone. So any hands up for some questions? Oh, we already have Nora here. Pass to you, and then at the back, yes.
Thank you very much for all the presentations, really nice. I have a question also in relation to the last presentation. It's very interesting because coming from a non-endemic country, but working in travel medicine, we have seen, and there's been case reports, especially in European settings, where one exposure to fresh water was enough to develop genital symptoms. So I was wondering, when looking back at the other algorithms where, you know, criteria was listed with what type of exposure or the distance to water, is that, my question is just, does it have any relevance, or what is the evidence base for that, especially when you are an endemic country, and also in view of urbanization, migration, and travel? Thank you. Maybe, I don't know, who, for whom? No, just in general.
I will just let one more person ask a question, and then I will hand over to the speakers. So I think we've got somebody back here.
Thanks. Yeah, Peter Deagle, Lancaster Uni. Is it known if, and if so, to what extent, geographical variation in FGS mirrors schistosomiasis variation? Because if so, then the schisto oversampling study could provide a very useful canvas on which to design studies where you deliberately span the ranges of risk.
Actually, that's quite interesting, and I wonder if there's overlap between the countries that were involved in the schisto oversampling study and the FGS burden, and if there's looking at that. Yeah. Right. So shall I hand over to some speakers to answer some questions, and then we'll take one there. Who would like to have a first go?
So I can make some of a comment to your question. I think you had asked about I guess maybe the usefulness of some of the measures of childhood exposure or distance to fresh water, those sorts of things. So in at least in our study, and I can't speak to, I think the majority of the work that's been done has not been done in urban areas. But when we were developing our tool, we did include those sorts of questions, and none of them came out because they weren't common behaviors, right? That people were not, regularly, engaging in washing their clothes in freshwater swimming, this sort of thing. But what we did see was, as you said, maybe they reported one trip to see family in a rural area, right? And maybe that was the only environmental exposure that was reported. Or certainly growing up outside of an urban area, was also important in our study. And I liked what you said about, urbanization. There's a really interesting paper that came out a few years ago now, I guess, about climate change and about how climate change is also affecting kind of this map of where, schisto is endemic, and I would assume would certainly impact the distribution of FGS.
Would any of our other speakers like to talk to the point about contact with fresh water, or about the overlap with schisto prevalence?
So in Ghana, we also were involved in the schisto oversampling survey, and we chose one district, one region called the Volta region, right? And that was where we got most of the cases from, near the Volta river banks. And also, we are getting cases of female genital schistosomiasis from there. It has been recorded in the Volta River Authority Hospital. We had a training over there, and some of the gynecologists came out and openly confessed when they saw some cases of FGS. Yeah, so it's overlapping. All right, thank you.
Thank you. Shall I take a question here?
So it's sort of my name's Gary Weil from Washington University. I don't belong to this club, but I have kind of a emperor new clothes question. Urinary schistosomiasis doesn't just cause female genital schisto. It can lead to bladder cancer. It can have ureteral stricture and hydronephrosis. So it seems to me that the issue here is that the schisto programs focus on school children because they are the biggest, they are the most affected. It has the biggest effect on their health, but that generally for females and perhaps for males, you want to know if somebody has schistosomiasis, not because if they don't, let's say they have schistosomiasis, but right now they don't have symptoms of female genital, but it doesn't mean that they won't have it in 6 months. So would it make sense to screen for hematuria as part of general health screening in endemic areas, or screen, or in other cases, do routine screening of urine for eggs, and then treat anybody who's infected, whether or not they have these symptoms. I don't know why the focus is on this when it causes other illnesses.
I will take one more question.
Just the blood and urine, would it detect what percentage of cases would it detect?
Yeah, I think there might also be a question of women who already have FGS and what is there for them when they may no longer have eggs, but they do have FGS. But you are right, it causes other things. Yeah.
Yeah, thank you very much. Wellington Oyibo from the University of Lagos. And just to say that I appreciate the grand truth that was laid by Christian, and of course from the presentation from Zambia, because it's very important we have all of these clear as we look at the case definition. And my comments will be to Ghana, that surprisingly you seem to be in an advanced state of FGS monitoring, because you already have FGS in your DHS one tool, you're capturing that. We're struggling to capture NTDs, even in HMIS in Nigeria. So, and while you were saying that, you talk about the resolution of cases, that were diagnosed with praziquantel. You said they were all good, but I didn't hear a follow-up, whether follow-up was done, whether the grand truths were established. That came up also in Nigeria, to see that there was resolution based on clinical presentation. So I was just wondering how this occurred. And then, of course, for Christian, I was wondering if the differentials were done. I would love to see the differentials on STI and then FGS, if it was done, if you have data. Thank you very much.
Thank you very much, Wellington. And so I will pass over to the speakers. Shall we start with Ghana, and maybe Gladys, you would want to take for Tanzania, and then I'll hand over to Kristen? Yeah.
I think Gladys should take it.
All right, all right.
Yeah, regarding the MDA for adults, it would be nice for males or female who are eligible for MDA to be given MDA. But the reality is there's no much praziquantel in the country. Although there are other tests that could be done, we still have other diseases that are of interest. So schistosomiasis is still a neglected diseases. So if a person who comes with symptoms that mimic schistosomiasis would be given other tests rather than neglected topical schistosomiasis. And yes, so if we were to have a praziquantel for everyone, especially in endemic regions, it would be given to everyone in Tanzania, at least.
Yeah, we did not capture the data on the resolution. That's why I'm quiet about that. So maybe.
Sure. So I think in terms of your point, I think most, at least from probably the point of view, of the group here, there are 56 million women and girls living with FGS, and I agree that hematuria testing, looking for eggs, prevention of FGS is incredibly important. And I, from having done this work in with adult women in urban settings, I'm of the mind that we should, I think historically there's been a real focus on, oh, this is a problem of school-age girls in rural settings. And I think that we should shift our kind of view of that. But you know, I think it's kind of two different questions. One of prevention, and then, you know, one of, well, how do we diagnose and help these, you know, 56 million women and girls living with FGS? And those numbers are really staggering. I think they, in terms of, they really kind of overshadow some of the other problems, I guess, that FGS can cause, which are important, certainly, to, I'm sorry, that schisto can cause, which are important to consider. In terms of your questions about ground truth, I think that's incredibly important, and it's something we haven't really talked about. For people that do FGS work, I think people, you know, you may know that our gold standard diagnostic tool is not infallible, and in studies where they've had 2 independent reviewers reviewing, or, you know, looking at a cervix, reviewing images, experts, they disagree sometimes, right? So in our study, in the 500 women where we developed the screening algorithm, we only had 1 independent reviewer, and that is a flaw, right? In our follow-up piece, we did have 2 independent reviewers that separately reviewed the, for lesion resolution, change in lesion or resolution, and we were happily surprised that they agreed about 80% of the time, which was better than I thought, you know, we would get just based on previous data. In terms of the STIs, I don't have those numbers with me. I will say that in our, we published on this a few years ago, in our larger cohort, we do see some association between past or current infection with schistosomiasis and HIV infection. We had very few seroconversions in the group of women that we followed up, this 43, as you might expect, so we couldn't look at the association with HIV incidence. In terms of prevalent STIs, we did have a fair amount, so 7 to 12% of women would have, you know, an STI at this time that we did our kind of cross-sectional survey, not associated with FGS though, which was interesting. We thought it might be, but we didn't see it in the data. Did that? Okay.
We have a few more minutes before we release you for a coffee break, a well-earned coffee break. So I'll just hand over to Victoria, and if there's yeah, okay.
Hi, I'm Victoria Gamba from Kenya, gynecologist in practice, and I also do a bit of work on FGS. So I just wanted to clarify on your question about urinalysis being used as a proxy for FGS diagnosis. So when we look at most of the literature, most of them actually find that up to 2/3 of cases of FGS are missed when you actually use urine as a screening tool. So it is good as a start, but it cannot be the only one, okay? So, and that's why I think for DTAG, and I'm looking at someone specifically over there, we need to do a bit more in terms of just trying to get something a bit more accurate for that. However, we need to start from somewhere. So my question would be, for all the presenters that have done, from a clinician standpoint, we know that the lower FGS affects all the structures around. So there's always one component that is not usually included. I just wanted to know whether you included looking at the vagina, because most times everyone goes to the cervix. That's all we know. And I'm just speaking about it because even I had to change that kind of perspective so that, because now I know better. So did you guys also try and look around, or was it colposcope is for cervix, full stop?
Yeah, and the ulcers.
Gladys, do you want to answer?
Yeah, so for our study, the trained gynecologist was to look at the cervix and the vagina. So for the, as you know, the colposcopy procedure is not that comfortable as well. Taking it and doing it might have some shortcomings. So for the vaginal vaginas we had from the procedures, it's only 2 of them that showed female genital characteristic lesion of female genital schistosomiasis. Although most of the colposcopy pictures we had, images we had, were on cervix.
Yeah, basically we also look at both places, right? But the focus was on the cervix. That was it. Because for the vagina, we're looking for the discharges and all that. But the focus was on the cervix, right? But maybe we can get some more education as to what we should look for when we look at the vagina. What exactly should we look for? For the cervix, we know what we are looking for. But in addition to what has been said, what are we looking for when looking? Yeah.
Actually, it's the same. It's the same lesions. Remember, it's the schistosome eggs, just causes inflammation. So this kind of structure that you expect to see is the same lesions. We're just saying for some of them that you might get a false negative because your focus was only on the cervix. That's all I'm trying to just take home.
Something also to remember that when we're talking about this area of the reproductive tract, we're talking about lower FGS. We're not talking about the stuff going on in the fallopian tubes and other areas. I think you had a question? Is that right? Yeah.
Hi, this is Nilanjan from Margaret University. It's a very good effort, like from all the countries, like who are trying to do and come up with like the algorithms and everything. So other than like Zambia, I think if I followed correctly, like all 3 countries, they have like pretty much trying to focus on like clinical signs and symptoms. And when the Zambian presentation started, they started talking about like the STIs and other things. So my question is like when you were talking about like the prevalence based on the data, how sure you are that this is like FGS prevalence versus other things? That's my first thing. Second thing is that STIs are pretty predominant across, depends on like which part of like the globe you are. And there is a trend of like misdiagnosis plus also the drug resistance too. Same thing for hematobium. But in all the 4 studies, if I closely monitor and the question that came from like the Washington University, what is the effort of like pinpointing that this is hematobium? Because this is still schistosomiasis. It has a female genital schistosomiasis name because it's causing like separate types of like clinical signs and outcomes in the females, and that's detrimental for their like childbearing and reproductive health. But still schistosomiasis caused by hematobium. So what's the effort being put in to pinpoint like this is the species we have that might get rid of like all those like false spots? Because coming from like the diagnostic point of view, I think I'm a little bit hesitant to accept that like really low specificity and sensitivity is around like 70%. So that's my major comment, like moving forward, like how you're actually, and the other things that you follow in the ground, because the climate change and other things came up, one other thing that did not came up is the hybridization, and that's mainly happening with hematobium too, rather than Mansenai. And most of the data that we are seeing, I think in last ASTMH meeting, there was a session and somebody asked like, okay, is this all hematobium cell like hybridized? Like, it might be happening at a very extensive stage, and it's already being found in all 3 countries, and I think Zambia is trying to look for that stuff too. So it's important to know like what's happening at the ground level. That might give you much better idea, and advocacy and policy wise, that might get much more traction. And my last point is like, what's the effort of like working along with like the surveillance team that's actually doing work for Mansenai and hematobium, instead of like keeping this one as like a separate entity, because we know like the resources, fundings, everything is very much constrained. So, yeah, thank you.
That's a fantastic set of questions that I think is actually going to be really useful when we're making our discussions. I'm going to give the speakers a chance to quickly answer some of those or give their opinion on some of those, and then we'll go out for a coffee. And then when we come back, there'll be an interview and the group session. So who's going to bravely try and tackle these questions? Looking at the speakers. Akin is getting away with being online. He doesn't have to answer anything. Yeah. Shall I handle? Yeah. Would you like? No? Want to ask the discussions? Yeah. Well, I think it's definitely something that will hopefully come up through the studies that are being done. The FGS prevalence studies might also tackle some of those. If there are no attempts to answer these, shall we leave them for the discussions? Yeah? So I think...
It's on. I just wonder if we should start. It seems a bit more empty than before, but I think we continue. And for the first part of this session, I have the pleasure to announce and introduce Dr. Victoria Gamba for a structured Q&A session to provide a perspective and account from a gynecologist on key considerations for the effectiveness of FGS diagnostic algorithms within existing health system. So for those of you who don't know her, Dr. Victoria Gamba is an obstetrician and gynecologist from Kenya, and she's a consultant at the Department of Vector-Borne and Neglected Tropical Diseases at the Kenyan Ministry of Health. She's a strong advocate for gender equality and promoting sexual and reproductive health and rights in girls and women. And she's a clinical lead for female genital schistosomiasis, cervical cancer prevention and screening, and she has led and managed many projects at national and international levels for integrating NTDs and cervical cancer screening into primary healthcare services systems. So, as said, there will be a set of questions addressed to her, and after these questions, we will then open for more questions to the audience. So, Victoria, the first question to you is, within your own practice and your work experience, do you have any examples or insights, lessons learned of what has worked well to integrate FGS diagnosis and services into routine sexual and reproductive health services?
Yes, I do. I hope I'm audible. Okay, so I'm Victoria again. I'm from Kenya, and as you've heard, I'm an obstetrician and gynecologist. Within our practice, what we've tried to do, especially in Kenya, because we are more at the clinical level, what we've tried to do is, at integration, we've tried two different approaches. There are two areas that we've specifically worked on, in Homa Bay County and Kwale County. Now, Homa Bay was the first one where we got the grant in 2020, right at the heart of COVID. So we really tried our best to continue with the work. So mostly what we did in the integration approach, it was more of a horizontal integration where we took the healthcare workers, the community healthcare workers, and then also we did a sectoral approach of integration where we looked at, we had the LVCT team working with the Ministry of Health. So with that, we leverage on now an existing program that was an adolescent health program. It's called DREAMS. And we were able to reach the community and tell them, you know, there's something called FGS. Of course, we have to start, there's schistosomiasis. It's in your county. And this is how it can also affect these other areas, and this is how you get the risk of it, and also exactly how it presents. So we were able to do that, and a few women actually came up and we did the integrated screening. And from that, we had a few learning points from there. We'll get to the barriers as we continue. But the good thing with that approach, we managed to get a whole spectrum of people, from adolescent to women, and even older people actually came in. We were surprised. So we were able to get a varied, you know, kind of experience. Now, in terms of just trying to understand what exactly worked well on that, it's because we knew exactly what we wanted to do. So we were very clear. We wanted to integrate FGS screening and diagnosis into cervical cancer screening in an adolescent program. So that was one of the things that we did quite well. And then we knew exactly where we wanted to integrate it also. So we had the product, the intervention itself, and we knew where we wanted to integrate it. So for the healthcare workers, the actual thing that they actually enjoyed was, it's a pelvic examination. So it's one. So someone just comes, you tell them, okay, if you're here for the cervical cancer screening, we can also offer FGS screening. So it was combined into one, and the step barely adds a minute or two. And that's why I was very keen in terms of, are you looking at the vaginal walls? Because we have 4, the anterior, posterior, and the lateral. And how you do it makes the difference, because if you do it in a painful way, you've lost that patient. And in fact, she will go out and tell the rest. So you will literally have no patients. So that is some of the things that actually worked. Then now in Kwale now, once we figured out what exactly and how to go about it, it was a bit smoother. Of course, the bumps, we'll talk about it again later. So what we did was, the approach was more wholesome. So we integrated in terms of the vertical approach from the ministry to the county level, sub-county level, to the community leaders. We did even barazas, we call them barazas. So where we call people so that we have this, talks about just schistosomiasis and then how it affects people. So we had really a whole cascade of people. And one of the things that I liked from the people from the ministry, from the county level, was actually they were happy that for once there was an intervention. So you can see, because everyone has come, they've talked about schistosomiasis, and they've left them with the prevalence. So they're wondering what to do next. So that was a plus. And then the next thing was in terms of shared cost. So we did the multi-sectoral approach also, where we had the USID, LVCT, and it was a safe-funded project, yeah. So yeah, we had all teams, so people could pay the healthcare workers for the time or the duration of the ceremony, or the training. And then we had, for the actual training materials that were needed, this team took over. So there was a lot of shared costs, so it really worked for that. And then the other thing that happened was, we were 3. So in terms of knowing how to do it, we had very influential people who could help. So we had the community leaders, and mostly the spiritual, the religious leaders who are now happy, to go and sell, this is not STI. You shouldn't be worried if you're having this kind of a discharge. You should also come and seek services. So we saw quite a big amount of people coming to just seek services, because now they're no longer stigmatized, because you can imagine if you have FGS, you've been treated severely for STIs, but it doesn't come with a face, it just comes with a presentation. Everyone, anytime you have any inflammation or infection, what you generally get is a response. So if you have, I can give you the next best example is your mouth, the inner lining. So anytime you have any kind of infection, of course, there'll be a lot of mucus secretion or something like that. So in the vagina, that comes out as vaginal discharge, okay? Then now, if you have any ulceration, you can get that, and it's painful. So none of that is very specific for any of the disease process. So you have to go the extra mile, and that is what we are lacking. So what I'm happy is that is what we got there. And then for the patients themselves, they were happy when we actually took them aside. Of course, getting a gynecological consult was a plus in the rural area. So the one thing that they liked was that being told, or what is FGS, how does it present, and you could be at risk, and this you give your consent freely. So we didn't have even any women saying, I don't want to be checked. They were actually even recruiting each other across the line from different immunization packages. So we really went the whole spectrum, from the family planning unit, those who were coming to immunize their children, those who were coming for antenatal clinic, postnatal clinic. So we really did the whole spectrum. So that's what I can say probably worked for that.
Thank you very much. And you mentioned Kwale, if I'm right?
Yes.
Have you, Kwale is on the coast,
yeah.
and also a bit of a different kind of religion that in some other parts? Do you have experience, or in terms of comparisons of context, what worked, for example, in Kwale County to others? Do you have to adapt?
Okay. So Kwale County is predominantly Muslim. Definitely anyone female is very welcome to do any examination. So it was a plus in terms of that, but I felt most of the women were empowered by themselves, because when they come, you know, when you have an issue, especially with your genital area, you need help. You really don't quite care who's there, but of course there are those, you know, religious things that are there, but most of the time, most of the people we were having were mostly female. And coincidentally, all the people we worked with in Kwale were female. However, in Homer Bay, we had the male people doing the pelvic exam, but there was no one shying away from it. So it still worked, yeah.
Thank you very much. And so, yes, this leads into the next questions. Do you have any examples of barriers you came across in relation to FGS service integration and diagnosis of FGS?
Wow, I need a drink on that, but yeah. Okay, so in terms of barriers, there are many, and I think we've listed quite a number. Maybe I can give you a story of how it started, and then we can come up from there. So on my first day in Homer Bay, after our grant, we had gotten, you know, a proper grant. So we were starting FGS. We've written, you know, a whole thing on integration. So we were quite happy about it. So we went, we had infographics, we had everything. We had, you know, we were very prepared for this. Then we landed to Homer Bay. It was at night, so we said, I'm happy to be in my lake region. I'm also called Victoria after the lake. I went to sleep quite happy that now I have an intervention. Then the next day I woke up very early, 6:30 I think. I was done with everything. Then I was busy taking photos, you know. The lake is quite nice, it's quite vast, beautiful. I didn't even know the waters could be blue. Yeah, so, yeah, as I was taking the photos, I noticed on this side, there was a specific water point. It was kind of isolated from the lake, but then I could see young women and girls washing dishes, people, women with kids on their back, others on top there just playing with the water, very naked children, not adults. Yeah, so, and of course, you know, probably doing all those things that have come with billboards saying, do not pee in the water, do not, whatever, help yourself in the water. So I looked back at myself and I was like, oh my God, how do I go to these people with all the no's that I've written, you know, you're not supposed to do all this. So it really took me aback, and you can guess what I did. Maybe Anouk, you can guess what I did after that. I was tempted to, yes. Do you think what I did? I went. So anyway, I went to now do my training, but you know, at the back of your head, you're like, this is the very first time I realized this thing is bigger than actually what we know, because there's a lot more. We have so much theory, so much about FGS. If you look, you'll be lost. So, but the actual intervention at that point was not there. So what I'm trying to do is, at this point, I know it would be nice for me to list all the barriers. I mean, it's so nice because I look very learned, but I want you to see this journey of these women and how we're coming with this, you know, you have FGS, you need to stop using this water because it's contaminated. It won't stop. It won't stop at all. So when we look at that, now we can easily define and see the barriers, and you guys can have like a true picture of now, what do we do now from here? So that said, of course, COVID had taken almost 6 months out of that. So we were also hit with COVID as a barrier for that. And the second thing, as I said, was we knew the women that we want to include, but we did not know what to include. Because at a clinical level, it's very easy to say, this is your diagnosis, go home. But they're going home to the same point. So that is the pickle I keep saying we're in with FGS, or schistosomiasis at large. So we have that. And of course, the other barriers was always on the healthcare workers, because mostly we're looking at something we don't know. We missed it in our curriculum, and changing the curriculum is quite difficult. As we've seen, we are all here. I remember we had this in the first package as we were trying to see, we need to include it in the curriculum. But when they give you the actual steps that are needed, everyone takes a step back. So do we have people to have that extra push, even if we don't have the project? Now, and then the other thing was about the data capture. I'm happy with Ghana. They do have a way to capture that data. For starters, in Homa Bay, we didn't have, and we realized we missed a lot of cases, because I still get the consults to just, can you look at this? What should I do? Is it an STI? And I'm able to help with that. But in terms of just writing with a capture that these are the number of FGS cases we have, we didn't have. What we've just done is try to incorporate it into the cervical cancer screening form, and it's starting to work. And even as we're doing our assessment to just see how exactly are people taking this, it's working. So that is basically it in a nutshell, but I've tried not to, rack your brains with a lot of the list, but just try to get you to understand the people. Oh yes, and the other factor that I may miss is usually the relationship marking, because I'm trying to have you guys have this, systemic lens thinking. When you look at the woman, she might have the symptoms, but between her moving from her home to the hospital, it takes a lot. It really takes a lot. And the final bit is always asking for permission from the husband. So as we are pushing all this, even the men need to know they can be affected with MGS, and even their women can be affected, and they all need to do something about it without stigmatizing anyone or having now those intimate partner violence, all those things that come about. So there is a very crucial role, much as we want to focus. I think I'm trying to make you diverge a bit from FGS, because I've been forced to do it. And I see a lot of problems, so we need to define our problems completely. And then now we converge together by designing a good, way forward. And if you're not in the FGS space, I hope you are, you're feeling like now you have a chance to do something. I'm seeing a few smiles over there, so I hope that translates into an intervention. So I think I'm done there. Yeah.
Thank you very much for these valuable insights, and I think there's a lot of food for thoughts and discussion. So I now give the audience the opportunity to ask questions.
Okay, thank you very much. Mine is to congratulate you. Yeah. We already have a few thoughts around integrating FGS in primary care. Of course, which is critical, so that experience is good. I'm going to talk, first of all, on that experience, and then again to still unpack, like you said, leaving the critical FGS intervention to the wider area. While I was asking questions about follow-up, it raises many other questions around how long you follow up. Reinfection, the source of infection, we cannot run away from it. Part of my hypothesis is that we will basically have to provide the evidence that will be needed through FGS to see that schisto control termination generally is accelerated. Because yes, you give the medicines, how long do you give the medicines, how long do you do the screening, and that's the bigger scope Victoria was talking about. And I wanted to ask you also, how did you do with the medicines? Because we know that the PZQs centralized and they're not distributed along primary care. Even though there are opportunities around that, we talk about case management using current WHO algorithm. So the access to medicines, accountability of medicines, and then how do we use this evidence to get multisectoral interventions on dealing with the source of infection? And again, do we expect to see quite a lot of stigmatization when what happened is nobody's fault? How do we communicate around the disease? You have this water, useful lakes for us, unfortunately, either to a source of water or in the absence of infrastructure for bridges, we have to go through those. No fault of ours. Again, it brings up the kind of communication, the strategy that we have to begin to bring in. Why, of course, looking at the care, we have to manage, but then do other things. So that's my summation. Thank you.
So I think there were some questions to you. Maybe you just want to respond.
Let me respond to that before I forget. Yeah. So great questions. So far, I honestly understand what you're saying. And that is actually why there's a whole focus on this right now. And as you've said, in terms of reinfection and infection and treatment and, even just resolution of symptoms, there's quite a lot that we don't know. And also in terms of the treatment itself and the efficacy and how long do you wait for people before you do another review. We're in the process with the CIF team to try and just, try to align based on what evidence we have now, because at least we know there's something that works with the praziquantel, of course, and we know it works against the adult worm. So about effect and probably resolving the lesions, that's a story for another time. But we know it's there, it's working. For most of the women that we've given, at least the symptoms resolve. But the lesions themselves, they're obviously egg-related, and we're not giving any medication that is causing egg resolution. So those ones do stay, okay? The only good thing about, the chronic lesions or the granulomas, that they're chronic most of the time. So, and sometimes they're not symptomatic at that point. However, now the problem comes about when it brings about complications, and the complications we're talking about are those ulceration, increased susceptibility to now HIV and AIDS, and those are stories that we really have not even tried to sort out with this. And this is why the other multisectoral approach is important, especially now, because we know what is happening. We have a snippet of it. Fine, we need to do a bit more research, especially for us on the molecular level, to just understand how exactly these things happen. I'm happy there are people who are interested in the vaginal microbiome. And this is something that is very new in science. It's actually evolving. So we shouldn't feel bad as the NTD community that we didn't know that. But we now have avenues to actually try and see how it works. So in terms of the management strategy, I think this one borders across. So you always need to have a proper case definition. That one goes without saying. A case definition is anyone who's had contact with a water body, whether they're swimming, whether they're doing what, whether it's recent or in the past. And at the moment for Kenya, we have current expanded MDAs. This is the second year. So that history of also being treated is important, either in the MDA, because the dosage is the same. So remember, we're also giving a preventive dose for treatment dose. Pharmacists, if there are any here, so yes. So that is something, a lot of things that we really need to unravel there. However, now we've defined the case definition. With now we're going to the symptoms. There's that history of contact, there's that history of now presentations. As you've seen, the sensitivity is quite high. And as I told you, anything that affects anything, any mucosa, leads to inflammation. So any discharge you'll find will be very non-specific. There's nothing like this is FGS specific. It is highly unlikely. Or up until now, we've not gotten any, aside from the STIs, maybe gonorrhea and chlamydia. And even with the two, we still confuse both of them. So there's no one who can tell you, I've looked at the discharge and this is definitely FGS. So you need to go through all those checks and balances. You have the contact, the presentation, and now the diagnostic aspect, which is the colposcopy. For most of the centers that we worked in, we do not have the colposcope. In fact, part of the reason that this works is because I have other people who are willing to, give you the colposcope because you've done it before. They just, allow you. It's not even rental. they give you because they know you need it for the work you're doing and you'll return it. But you see, that's for that project. It's not, there's no longevity after that. So you're still in that space. However, the good thing is with proper lighting, we've also just been able to see with visual inspections. So if you know what you're looking for, you will find it. But the problem is when you don't know. And that happens to more than 50% of the people don't know what they're looking for. So with the training, it needs to be very, very, very clear what they're looking for. Yeah.
Thank you. I think there was one more question. We have time for one more question. Dr.
Okay.
Opare, you were.
Yeah, practically, under 15 years, okay? How did you manage them under 15 years, where you cannot do colposcopy or speculum examination? How did you manage them? Then also the treatment regime. Which one gives a better resolution? Is it once or twice? I heard from Tanzania once. I heard from Christian War twice. So what is your experience on that? In Ghana, we give it twice.
Yeah.
We give it, then after 2 weeks, you come back for a repeat. So in your experience, which one works better or best?
Okay. So for 15-year-old girls who are not sexually active, we basically just use proxy indicators. And that proxy indicators is the urinalysis, where you look for hematuria and the eggs in the urine. As we've said, of course, for them also, more than 2/3 will go undiagnosed. The good thing, they're in that region, which is endemic. So most of the time, you will not find the definitive diagnosis of FGS, but you will be able to have a chance to give them an MDE with that. So that's what we do normally for them. Of course, there are others who have early sexual debut, but you see the issue of consent also comes about. But if it's an emancipated minor who's given birth, then that one can be allowed to go for pelvic exam. But what we clearly state to the healthcare workers is we do not do a pelvic examination for anyone who's under 18 and who's not sexually active. So that one, there's a rule. And then in terms of the treatment regimen, I know you've looked at many studies, and most of them, they're trying to inform that. What I know works is the 8-week difference, because you can do a repeated dose of praziquantel. We know it takes the worm around 6 to 8 weeks to mature. So because praziquantel doesn't work against the juvenile forms, so you have that window to now give another dose after the worms have matured, and then it now kills the rest of what was probably remaining. And then in terms of resolution of the symptoms, you probably get it. And the 2-week period is mostly what we give if you do not respond to the praziquantel, because we know it's not FGS alone that causes the symptoms. So if you've not responded to this treatment, and yes, you might have had the lesions, then probably was not an active lesion. It's something that was there before, and we have given you treatment. It has not resolved. It is likely that you have another cause or a differential cause of it. So that's why we allow you to come back for reevaluation and treatment. What I should add is for most of these reproductive tract infections, we are moving to a time where we want more of the species identification. We are moving from, the usual empirical treatment or such kind. And what I want most of you to get out with is we're going to 2030. And a lot of things are changing. And there's a lot of push for self-care. So sometimes the colposcopy will work, but there'll be a big number of women who will also need self-care. So we need to be ready for that and actually offer, like the Bill Hill study, the way they're doing both HPV DNA and FGS in that. I think we need to marry into what is happening. If we really need the actual diagnosis, which I feel we need, because each and every time we will keep saying, it was a probable, it was a presumed, and I think science is moving. We want to know, what is it? Yeah, and we owe it to the women because they come as one person, but they have all these presentations. So will you say now, go to the FGS doctor, go to the, it can't honestly work. So let's try and have a more person-centered approach to this, yeah.
Thank you very much, and I think, these are very key questions, and still we don't have all the answers yet, especially what is the best regimen. It might differ. In Madagascar, they're having an RCT with a 5-dose regimen. So all that, we need to wait for results and, do what we can in the meantime, and also how to assess treatment, response, and cure. That's where I think we now continue into the breakout sessions where hopefully some of these points are being discussed. So thank you very much.
Thank you very much, both. And I hope you all agree that that was a really, really interesting discussion. And Dr. Victoria painted a very clear and interesting picture of the situation in Kenya and things that we can take forward for the discussion. So now we're going to have our group discussion, and there's going to be 3 different topics. So firstly, routine clinical settings. Secondly, prevention and screening. And thirdly, surveillance, mapping, and public health. So if there's slightly different questions for each group, and it'd be great if you could go towards the group that you think you're most interested in and can provide interesting discussion on that. So we'll stay in our group for the entire time and just focus on one area. We won't be moving around. So go to the area that you are most interested in. And our facilitators will support the discussion. So if you're interested in routine clinical settings, if you can come here. If you're interested in group number 2, prevention and screening, if you can move to this area of the room. And if you're interested in surveillance and mapping, you can go to the back. We'll have 35 minutes for discussion in your groups, and then we'll come back together and report back. Okay, everyone, can we wrap up, please? I know you're all loving this discussion, but we can't stay here for too much longer, so let's come back to the group. It's very interesting. Okay, are we ready? Yeah. Okay. Okay, so we're going to have feedback from each group. So if you can all stop and listen, that would be great. We're going to start with the routine clinical settings. Yes. So we're starting with group 1. And I think, Omosefi, you... And if you can give a very quick...
I'm usually very quick. Okay, so hi, welcome back. Welcome back. Welcome back. All right, so our group was talking about the routine clinical settings. And, all right. So we talked about the barriers for FGS diagnostics, and many of the barriers have been discussed in the room previously. And so we tried to provide some solutions that we could look at, like the self-sampling methods for women, as against encouraging them or making them go to the health facilities for some form of diagnostics. And then providing SOPs for the different levels of health to understand or know how to identify and deal with FGS, as well as as well as including the traditional birth attendants at the community levels, because many times women do not go to the health facilities first. They go meet the traditional birth attendants who, if they are not knowledgeable about FGS, then we miss those people. And then, like I said, the SOPs, having SOPs for different levels of health workers. Another thing we looked at was the effective components for FGS diagnosis. And so, like we've heard about previously, the risk assessment, scores and criteria for at-risk population. We also talked about social mobilization, because the language that we use to communicate FGS is critical to ensure that communities are involved in what we're trying to assess. And then the awareness, so awareness of the community members, awareness of the health workers, and like we earlier mentioned, the spouses and the leaders of the communities. And training, yes. So training about stigma, like somebody asked earlier, the stigma awareness amongst the health workers, because if they are aware, then they are better equipped to even interview clients when they come to the health facility. And then we talked about requirements for integrations of algorithms into our existing services and scale up. And we also know that commitments from the MOH at the different levels, policy, uptake of whatever interventions come up, capacity building of the health workers, and then having like a good or easy referral pathways for health workers to use from the communities up to the tertiary institutions. And then we were still at the point of gaps in knowledge for research. And so we really have being able to provide a more sensitive and specific diagnostics for FGS. Thank you.
Perfect. Thank you very much. Okay, so we'll pass straight on to group 2. Thank you.
Thanks very much. So we had a lot of discussions around a lot of different aspects of FGS and prevention and screening, which we did actually think were quite like two different things that we needed to think about, but they do feed into each other. So we had just a thought about the components for an effective FGS screening algorithm. And whilst we did talk about, based on the presentations that we heard earlier today, about how something like exposure or just generally the algorithms, you need to think maybe a little bit about the context. So is this an urban context? Is it a peri-urban context? Is it a rural context? Because the questions and the checklists around exposure might be different based on those. But then there's the question raised up about how do you do something standardized, and also how do you do something that's practical, that can be used if you're thinking about screening and integrating screening into different platforms, which is and existing programs, which is what we have on my right here. then it's got to be something practical that can be used by different groups and also at different levels of the health system, and as well as being something that might not be a gynecologist or it might not be a nurse that does this. And how would you think about something that could be used by community health workers? And then what do you think about, how do you think about something that can be used by those in the health services at the peripheral level, so the primary health service providers? So there was a lot of questions about that practical aspect and how to create something that can be adaptable and used in those different settings. We talked a little bit about how you would screen people, where would you be screening people that don't have symptoms? So it wouldn't be the case of people coming in with symptoms and saying, I've got these symptoms, can I get checked? It might be a case that you're integrating this into sort of maternal clinics or into immunization programs or something similar if you're trying to capture a particular age group or particularly around that aspect of prevention. So when we were talking about prevention, we were also thinking about sort of the age group that we're dealing with. And I'm just going to put that there. Oh no, there was something about prevention here. So we talked about having the appropriate manuals for community health workers that they can use to sensitize a community and then encourage them to go and to a health professional. And we also talked about how civil society groups and educational clubs, if they are sensitized on things like hematuria and certain symptoms, then they again can be encouraged to go seek help at health services. And leveraging child and adolescent platforms and also the use of mass media, which departed a little bit from the sort of algorithm discussions, but feeds into it. So yeah, I'm going to leave it at that. I think we had some other discussions around what platforms you could use, but unless anybody else from the group wants to raise something. No, good.
Thank you. Okay, and we'll just quickly run to group 3 for a very quick summary.
Anyone in the group who wants to summarize before I say anything? Maybe. Okay, so we've been going through lots of things. So one of the questions was the components of effective FGS diagnostic algorithm for surveillance and mapping. So we discussed about the 2 components, infection component and symptom component. So we still we still have to have the evidence of infection, and through those components, it would be since the symptoms of FGS and risk factors are non-specific. One of our members said maybe meta-analysis would be nice to know the common predictors of schistosomiasis, female genital schistosomiasis. And in terms of mapping, we discussed about mapping of FGS, looking at the when MDA is done to school-age students, maybe some of the elders, female elders, could be also be pilot in this mapping and could help in the surveillance of female genital schistosomiasis. And also, we discussed about praziquantel being given to these female women who might have female genital schistosomiasis for the treatment of female genital schistosomiasis. We also went to because we've gone back and forth, but yeah, so we discussed about second component, if I'm not mistaken, requirement for implementing surveillance and mapping, and we discussed about risk assessment and symptoms for FGS. In risk assessment, we talked about endemic areas, identifying endemic areas, but also activities that women do in this freshwater, contaminated freshwater. And if these women live near the freshwater, that is contaminated. And in terms of symptoms, we discussed about the non-specific symptoms such as vaginal discharge, blood in urine, and pelvic pain, and other symptoms for FGS. We also had a bit of a discussion on requirement to implement surveillance. At the community level, we discussed about having volunteers who are trained on identifying symptoms and know the case identification for female genital schistosomiasis, but also the healthcare workers in those facilities to be trained and educated on female genital schistosomiasis. And for the young girls who are 12 to 14, who are not sexually active, but might have the symptoms for female genital schistosomiasis, to be identified or treated for female genital schistosomiasis. At the health facility level, healthcare workers should be trained on colposcopy use, and the reporting form should be formulated for case identification and reporting. Also have poster or flow charts, and to really understand that FGS is not STI, and to identify the difference between STI and FGS. I hope this makes sense.
Thank you very much for all of the wrap-ups, and I'll be very, very quick because I know we're at time, or almost. So firstly, I would just like to say thank you to all of our amazing speakers. You want to say one?
No, just to add a bit of a silver lining on it, I didn't finish my story. I gathered courage the third day and went and talked to those women, and some of them actually came for screening. So that's one. And then number two, I'm happy with the SIF project that we're doing, because a lot of these things that you've raised are coming up. And we've realized we need a more generic tool that can now be adapted in different context-specific environments, but it gives you a structure. What are we looking at? What should we look for? And then now, and it's targeted for different groups. There's the healthcare workers and the community health promoters. For us, we call them that. So I hope that gives you a bit of perspective when you go.
Thank you very much, Dr. Victoria. Yes, so thank you to all of our speakers for providing really interesting insights into their research in the different contexts. Thank you also to our facilitators for the group discussion. And thank you also for all of your participation, because I know there's been a lot of questions in the room, but that's how I know we've achieved our objective of thinking about those research questions which remain, which there are a lot, but I think that's progress to start defining those and thinking about next steps. And then thank you to everyone who also participated online. Including Dr. Akinola, who actually participated on the laptop in that working group. As I told you, he's following avidly online, and I would just like to very quickly, if it's okay with you, give the responses that he provided to a couple of questions. I'll be very, very quick. So in terms of the water contact, he said that why you think about different water contact practices is to establish if they've had any contact, because that could lead to infection, but also more frequent is more likely to be a higher risk of infection. And so you need to identify schistosomiasis, because without that, there won't be anything. And then the countdown training tool actually provides a flowchart on the care pathway. So it's a useful tool, especially in resource-limited settings, which I think is a good thing to part on, that again and again, what's come up is that the context is very, very important, and we can't just think about what is the most effective diagnostic tool. We also have to consider the context, what resources are available, and the capacity. So I'll end there, and thank you again so much.